Very serious occasion. We very much enjoy your support and your vision in Africa and African Union and WHA. I spoke to Dr. Al-Mandhari this morning again. As you know, he's been very busy. The title for the session is Amana upon our shoulders, was his plea or cry for help in a time of very difficult times. And I'm glad Egypt answered with the help across the world. Then I would like to also thank Dr. Mariam Jashi, who is the Deputy ex-Deputy Minister of Health from Georgia. Thank you very much, Mariam. Mariam heads the Medical Women's Association and has been very supportive in changing that. Then I would ask Dr. Ahmed Al-Mandhari, who is doing two caps today. He is representing Dr. Al-Mandhari, and he will then come in his own rights. And then I would like to thank all the contributors from the Personalised Cancer Care, from pharma, and then from the International Alliance of Patients Organizations. We have our board member, BC Pratt. BC? So please approach it. Thank you, BC, for hanging on to so late time. Thank you. And then the thousands who helped us along this, and obviously NSAs. I'm glad there's a table at the top with young doctors from the region. Doctor from Morocco, I have MSA when she finished here. Hi, thank you for that. And the other NSAs who have been supporting us during all this period of time. Without much ado, could I ask Dr. Ahmed Al-Mandhari to start the session? Dr. Azim.
Thank you so much, Excellencies, colleagues, ladies and gentlemen. It's a great pleasure and honor to be with you tonight, and as was just said, I have the honor to represent my regional director in the WHO Eastern Mediterranean Office, Dr. Ahmed Al-Mandhari, who is very busy, of course, at the World Health Assembly this week. And then I'll have also the pleasure to just present a few slides as an overview of cancer prevention and control in our region. And I'm very pleased to have been invited here with colleagues from WHO headquarters, of course, with collaborators from around the region and around the world. So let me start with a message of Dr. Ahmed Al-Mandhari, our regional director, for this meeting. Let me express again the appreciation of the regional director for the kind invitation and for aligning the theme of this meeting with his regional vision, which is the EMRO Regional Vision 2023. And indeed, in assuring access to healthcare and the alleviation of suffering is a duty that we all carry on our shoulders. And I looked up the word Amana, of course, on Google, and learned that it meant trust, faith, and integrity. And I believe these are the credentials that we all need to work in this important area of work. So the aspects of the 5 Ps of the work of the Personalised Cancer Care Alliance and the paper, the position paper that was kindly shared with all of us, resonate a lot with the work that we're doing. And the predictive, preventive, participatory, personalised, and preemptive health care that guide the Alliance align to a large extent, at least, with our work in the WHO towards the overarching regional vision, health for all, by all. That's what Dr. Al-Mandhari actually brought to the region, to the regional office rather than WHO when he joined 5 years ago. So we need to refocus our joint efforts on cancer prevention, early detection, by addressing the known risk factors guided by WHO's normative work, such as the NCD global agenda that we very much have adopted also in the region through our regional committees and our health ministers. But also, I would like to highlight that the updated NCD best buys from the Global Action Plan that are going to be hopefully ratified in a new extended form tomorrow in the World Health Assembly. So that's important to us because they also address cancer prevention and care. And when we talk of cancer prevention, we very much mean, of course, the fight against and other important risk factors. So WHO's recent global cancer initiatives, including those on breast, cervical, and childhood cancers, provide an opportunity to focus attention and create a platform to improve advocacy and practice for cancer control in our region in the Eastern Mediterranean. I'll show those ones who are not familiar with the Eastern Mediterranean region a slide in just a few minutes about the exact countries that we cover and that we serve. So WHO calls for greater investment in cancer prevention and early detection, the harnessing of country leadership, and the use of high-quality tools that balance the benefits, risks, and resource implications of routine cancer screening programs. Promoting the early diagnosis of cancer is crucial given the late presentation of many cancers in the region. It is the foundation for improving cancer curability and survival, particularly in low-resource settings. It is important not to overlook that personalized and population-based approaches to the screening, early diagnosis, and management of cancer have to be guided by solid and rigorous scientific evidence. That's obviously what the WHO also stands for. Hence, we need to invest in generating and disseminating quality data on cancer at national, regional, and global levels. And this underlines the importance of well-resourced cancer registries that many of our countries in the region and around the world are currently developing and improving. I would also like to highlight that the genetic makeup of individuals is part of the personalized cancer care environment, as it is enabling or disabling the onset of presentation of cancers. And I think much work is ongoing in genomics, and we have to carefully monitor the scientific evidence there as well. It is important to note that our region is very diverse and hosts countries with a wide range of socioeconomic contexts, meaning that some countries are able to cater to personalized high-tech solutions now, whilst others still struggle to offer more basic cancer prevention and care interventions to every individual due to acute or protracted crisis. Let me also highlight the importance of engaging people with lived experiences of cancer as accelerators of change. And I know that many, if not most, or all of us in the rooms, have experience through ourselves, our families, or our communities. And I have learned myself that this is hugely important for, I think, moving forward our agenda. So those colleagues and people and friends and patients who do have lived experience of cancer provide valuable experience, knowledge, and wisdom that can help shape inclusive, appropriate, and effective cancer programs. Finally, we need to remember that the COVID-19 pandemic has taught us that cancer care should be part and parcel of every country and country's emergency preparedness. We actually say now, I think in this assembly in Geneva, emergency prevention, preparedness and response plans, which is good because it includes all the preventive work that we're talking about, so that we can ensure that essential health services such as cancer prevention and care are maintained also during emergencies. And I think that is a lesson that all of us have learned, and certainly I have learned also from colleagues around the countries that we serve, that the COVID pandemic really lay bare the vulnerability of cancer sufferers from pandemic events and the related logistical, economic, and other challenges. So in this way, by addressing and thinking about those issues, we can build better and in the spirit of Amana, and I wish all of you a very successful event. So those were the words.
Thank you very much, Dr. Azouz. I do thank Professor Al-Mandhari. I think he's lessened our burden and we'll go along with him. Now, before I call on the Minister to come and speak, I've personally to acknowledge something. My grandfather was treated by the famous Professor Magdi Yaqub. My surgeon, Mr. Farid, was Egyptian. He designed my rostrum, beautifully done. I'm sorry I won't show you that, but I'm so proud of his work. And my clinical team as well was from Egypt. So I'm thankful to Egypt for that. I'm made in Egypt. Honored to be made in Egypt. And I would ask Dr. Khalid Gafford to honor Dr. Khalid Gafford to come and say some few words to us. And thank you very much.
Good evening now. I think it's one other beautiful day out there in Geneva with nice sunny weather, but everyone is working and busy with the assembly. So I'm glad to join this important event, and I have to applaud the Personalised Cancer Care Alliance for organizing such a beautiful, important seminar and gathering through the organization, and delighted to be here and to start the opening remark. Thank you for inviting me and giving me this honor for putting down my remarks at an important scientific and informative meeting that comes to represent a great opportunity to exchange our views and experience. When I'm on my way coming here, we all as a political part of the health sector, we think about most of the time patient-centered healthcare, right? So now you listen more about patient-centered healthcare. So when I looked at the position paper that you just mentioned, and about this important symposium that we have right now about personalized cancer care, so I think we should go even more personalized and be more precise to move from patient-centered healthcare to personalized centered healthcare, so that we deal not just for the patient in general, but for every particular patient is a personalized object for us to work with and to concentrate. And that's difficult, I know, but in the future is going that way. So I would like to start my remarks by highlighting that the use of personalized medicine that we all see coming become increasingly important in healthcare, and it allows tailored treatment plans that are specific to each and every patient. Egypt has a strong commitment combating cancer with a focus on early detection, and we had a lot of initiatives that work in early detection of different NCDs and certainly with cancer as an essential tool for this important target. And our success story marked the launching of presidential initiatives that aim in prioritizing health concerns. One of those is relevant definitely to cancer. We can talk about that, but I think my colleague Dr. Ahmed Morsi will have enough time to elaborate more about the initiatives as regards to Women's Health Initiative in particular, that serves to detect cancer at a very early stage, and it was very evident that using the personalized approach that we adopted in diagnosis and management has reduced the likelihood that cancer reached advanced stages as was the case in the past. I remember when I checked with my colleagues the numbers and figures, we used to discover breast cancer, I think like maybe 97% or 69%, almost 70% of the cases we used to discover it on terminal stages or stage 4. But after moving through the initiative, we reached now like 29% only. So that's how we helped a lot for those patients to early diagnose them, and certainly we managed to treat them for free at early stage. So throughout the initiative, healthy and health equity was one of our main goals, which is important because we all know that cancer therapy is quite expensive, and we cannot just leave it for rich patient to get it and poor patient not to get it. So we managed to do it on an equity basis, and have the government being responsible for that. So more than 18,000 has access to the best techniques for diagnosis and updated guidelines for treatment with introduction of new basic drugs. Different lines of hormones, endocrine treatment in 70% of breast cancer patients, helping those patients to avoid the adverse effect of chemotherapy and achieve effective treatment and better quality of life. Ladies and gentlemen, the Egyptian companies, on the other hand, has also created a global partnership for technology transfer, localization, and joint production of diagnostic tools and medications, and for producing combination therapy for different oncological diseases, which played an essential role in supporting many national campaigns and initiatives. Adding to this, there is a condition dialogue and research to try all those innovative medicines in a cost-effective model of implementation. And that was also helped by our clinical trial legislation that we just launched a couple of years ago to help in improving the research and development in that field. As for the next step, we are setting out to initiate a network of genomic center. And I mean, my colleague talked about that, and also in Egypt, we just launched the Egyptian Human Genome Project 2 years ago. So we are having an ongoing genome project, a huge project. So that will also add a lot of help for the genomic screening that we are targeting. And based on this high-level commitment for manufacturing and developing biomarkers, I'd like to give examples for using biomarkers as also in several levels, including research and diagnostic levels, demonstrated in Egyptian CDC. And also this is another achievement that we had during the last couple of years. And together with one of important universities, in Shams University, we had a genomic unit that is highly equipped to provide both diagnostic as well as research services for cancer cases in general. And with this Masri Research Institute and Shams and the Egyptian CDC, we managed to provide a distinguished service center patient through free approved in vitro diagnostic molecular biomarkers for lung, colon, and breast cancer. When we go to immune therapy technologies, we have also demonstrated in the important Masri Institute the highly specialized laboratory equipments needed to isolate and manipulate immune cells, as well as to genetically modify them as needed. In addition to specialized facilities that are required to manufacture and administer immune therapy products that should strictly adhere to strict regulations and guidelines to ensure safety and efficacy of the immune therapies. Ladies and gentlemen, I would like to emphasize Egypt's commitment towards achievements of quality care for cancer patients for everyone with equity. By investing in the biotech industry, Egypt is ensuring that patients receiving treatment that are tailored to their unique needs, improving patients' outcome and reducing healthcare costs. And I thank you.
Thank you very much, Minister. I'm selfishly going to take this time from you for one brief moment as well, a vision of mine. I'm a colorectal cancer patient from Kenya. I was born and brought up in Kenya. In days gone by, they used to say, from Cape to Cairo, thinking if technology has to spread, it's going to be Cape to Cairo. I want to change that with you, from Cairo to Cape, the other way around. Let's make sure Egypt is better. And please ensure that the African Medicines Agency is up and running. It is performing as it should. So a patient like me, anyway, from either Cape, Cairo, from where at Cape Verde, or down to Djibouti, gets that technology at the right time, at the precise time, as with the patients. So thank you very much for your time, and do take that message back in there. For African colleagues at WHO, we do need that agency. Thank you. Okay, now I will ask Dr. Asmus to come and present his actual vision on WHO, the statistic and epidemiology, and others. Dr. Asmus.
Thank you so much, and sorry that I have to be here a second time, but it's my evening, I guess. No, this one is better. Thank you very much. So I was very kindly invited to just give a few slides. I'll try to wrap them up in less than 10 minutes, and to give a brief overview of what we're doing in the WHO with our member states and constituencies in the cancer prevention and control. And if I may start, with a few introductory words before going into the regional burden of cancer, some of the regional specific challenges, possibly the response and opportunities and the way forward. So the Eastern Mediterranean region is a very diverse and interesting group of countries that in yellow here on the screen between Morocco and Pakistan, and it includes basically three socioeconomic income groups: the wealthier countries or the wealthy countries in the Gulf, middle income and higher middle income countries across the region, and then also some countries that are either in crisis or have lower socio-economic indicators at the moment, and therefore, of course, also have different challenges when it comes to cancer prevention and control. In summary, cancer is, of course, a major contributing cause of morbidity and mortality in our region. I won't read the figures to you, you see them. And it's the second cause of non-communicable disease-related death after cardiovascular disease. We have one of the highest speed, so to speak, in terms of developing new cancers for different reasons. Of course, I'll come to that a little bit later. And we have our profiles of common cancers in men: lung, prostate, liver, colorectal, bladder; in women, breast, colorectal, liver, thyroid, and ovary. And you can see on the right in different colors the basically incidence rates of cancer across the region. In terms of mortality from cancer in our region, on the left we see that I think this is both sexes together, just a repetition of what I just mentioned: breast, lung, liver, are big ones, and then on the right you have gender or sex disaggregated data for women on the top and for men on the bottom. And most of these figures are actually from the International Agency for Cancer Research, or sister organization in Lyon, France, under the WHO, the so-called Global Can data from 2020, which I think were probably taken in 2018-19 from the WHO Global Health Observatory. So cancer trends in the EMR, we see the expected growth, which is very significant. I think it's one of the most dynamic in a way cancer trends in the world of any of the 6 regions of WHO globally. And of course, it has to do with epidemiological changes due to simply more people being there, population growth, but also, of course, an aging population. And the higher risk factor prevalence in our Eastern Mediterranean region is clearly related to tobacco use, to a relatively high body mass index, obesity in some settings, physical inactivity, certain diets, suboptimal breastfeeding practices, and to some degree also infections and perhaps environmental factors. And every third cancer in adults aged 30 years or older in our region, at least in 2012, was due to modifiable risk factors, and that's of course an extremely important fact for policy making and for public health policy in terms of what can be done. So in terms of challenges in impeding an effective cancer response, clearly there are contextual challenges, and unfortunately several countries of our region are currently in emergency situations, as we all know. Governance plays a major part, of course. The stability of the system is an important determinant for effective cancer care. We all know that instability also triggers a brain drain, despite all the good intentions that we all had over the last 20, 30, 40 years. we see, of course, health workers leaving countries when conflict arises naturally. And we have lifestyle risks related to cancer, as was just mentioned, paired with a very high tobacco use overall, especially in males, at an average of almost 20%. We have financing challenges, of course, in terms of benefit packages for universal health coverage, despite the many good efforts on most of Egypt, of course, with its universal coverage scheme, and there's many other country representatives, I'm sure, in the room who can tell their efforts and examples. But still ongoing relatively high out-of-pocket payment, regionally over 40%, limited public funding in some areas, at least some countries, relatively high cost of cancer medicines and technologies, and at the system side, of course, always the issue of political commitment, but also the human resources, the technology that it takes, the financing, and also the data. So the health system as a whole, and therefore the country's economy, I should say, is a major determinant for effective cancer response, of course. Just a couple of slides on the particular challenges that our populations face in emergency settings, where we have now increasing evidence, of course. I mean, in a way, it's common sense, but I think we also need scientific literature and evidence, and that's slowly developing in terms of people with NCDs, especially also cancer, being at higher risk for mortality and morbidity in emergencies. And in a way, COVID-19 taught us a lot of lessons there as well, in terms of interruption of services and people with living with cancer and other non-communicable diseases being very vulnerable. And here are some figures from our region in terms of the number of people affected, more than 40 million, the vulnerability of especially people living with cancer in terms of accessing their drugs, accessing those services, and all the effects, the health effects, economic effects that is having in several of our settings. So this is a source from World Vision, from an international NGO, which indicates for me also that we in WHO, even the United Nations system, don't have all the data, don't have all the answers. So we really rely on each other's research dissemination to inform that. And another source, which is not a WHO source, but a scientific peer-reviewed paper on cancer burden among refugee populations, which is quite difficult to estimate, and I think even in our region there's limited data, although many of the countries are working on those. It basically shows that many of the countries in our region that are currently having some sort of crisis, at least South Sudan is not in our region anymore, but used to be for a short time. And it just shows that basically cancer burden doesn't go away just because it's an emergency setting. It's quite the opposite. But it's not often made a point of discussion, and that's why it's so important, I think, that these data are out and we can use and quote them. So coming to the last part of the presentation, which is about I think our joint response really, because whatever we at the global level publish is everyone's work and everyone's effort. I hope that most of you have seen the Global Action Plan for Prevention and Control of NCDs on the left. And it's very much about accelerating national responses, prioritizing and scaling up implementation of the best interventions, coming back to the best price for NCDs and for mental health. And also, as we said earlier, the timely, reliable, and sustained national data generation. And I can confidently say that our data are only as good as the data we're getting from our countries. And this is why it's so important that we have the same kind of interest in prioritizing data through, for example, cancer registries in our region. On the bottom, you have also a little framework, which is a mini version for our region of the Global Action Plan, the so-called PEMRO, a regional framework of action that our ministers of health in our regional committees a couple of years ago have reaffirmed. And it's very much focusing on governance for NCD prevention and control, reduction of risk factors, surveillance, management, and research. And coming from those NCD, the NCD agenda overall to cancer and cancer guidance, there's a lot of these are global documents mainly, and very fast developing, especially in the area of cervical cancer, as all of you know, with global resolutions here in the World Health Assembly just a couple of years ago, but also with acceleration on childhood cancer, which is very important for us with a variety of donors, and also breast cancer. And on the bottom, that's an important slide. It's about the so-called impact reviews, which is a joint effort of the United Nations system with several of our agencies, including the International Agency for Atomic Energy in Vienna, Austria, but also our cancer research control colleagues in Lyon, France, where we basically support countries in analyzing their cancer systems from prevention to palliative care, and then try to also generate additional resources and support afterwards. So we've just come back from a joint mission, actually some of us from Jordan, and we've done it in many countries around the world and around the region. In terms of what we're doing in our office in Cairo, serving those 22 countries, perhaps the most important document is on the left. It's just a two-page, and I have extra copies in 3 languages here. It's a framework for action on cancer prevention and control. And it basically is very simple, or looks simple, but of course, as always in WHO, it is a consensus of years of experience from countries in our region that looked at with us at global guidance and said, for our countries in the Eastern Mediterranean region, these are the important areas: cancer governance, prevention, early detection, management, palliative care, surveillance and research, then a set of strategic interventions, we could call them best buys for cancer prevention care, and then a set of indicators, which may coincide with indicators that we have in other normative work as well. So this is really important for us, just to have this two-pager when we go to countries, because this is already agreed with our 22 countries by our ministers of health. So everyone agrees this is most priority. And then, of course, there's also adaptations, regional adaptations of cervical cancer, for example. So this is a regional version of the global one that I just showed. Again, just approved by our member states last year, actually, in our regional committee. And you see also there's a lot of events and a lot of interest in, I should say by now, all of our countries, certainly in the Eastern Mediterranean region. And a lot of the regional consultations are actually triggered by our countries, by population interest groups. It's not that, perhaps like in the old days, WHO was hosting all these meetings, but it's a really diverse landscape, including triggered by people living with a living experience. Just to say a couple of words, I know that not all of those are immediately priority cancers, as I presented earlier, but those are cancers that we are working on more extensively. What can I say? Because there's also a global and a regional momentum. And to be honest, also sometimes there's funding opportunities in childhood cancer, for example, with St. Jude's Hospital from the US. And that made it possible for us to scale up work on childhood cancer, for example, in Morocco and Pakistan, in Jordan, activities in Syria, Iraq, and Palestine, even under difficult circumstances, often, or especially. That's why, because many of our countries, as you know, like Iran, like Sudan, like Palestine, really are challenged of accessing high-level care because of sanctions and other complications. It's not just the conflict, but sometimes it's simply the economy and the global politics that hinder those services to reach vulnerable patients. So this global childhood cancer initiative, supported by St. Jude's Children's Hospital in Memphis, Tennessee, has been quite catalytic actually in some of our countries, and we hope to be able to scale it up in others. Then breast cancer is of course also a critical issue, a very sensitive issue also culturally, of course, in terms of early detection and treatment, and I think lots of good efforts are ongoing there. And then, as we said, in cervical cancer, because of the global and regional commitments, also the buy-in of new countries into cervical cancer, HPV vaccine dissemination, for example, including countries like Saudi Arabia that have come a long way in over recent years in terms of allowing this and acknowledging the challenge and the opportunity. We're doing quite exciting work, but we need everyone's advocacy and experience. Finally, always finally, it's palliative care. So it is advancing in many countries, but of course it's mainly provided as around the world in tertiary hospitals and nursing centers. I think also the definition of palliative care is quite limited in terms of only cancer and only advanced stages of illness, rather than other diseases and other suffering that may well be covered. National standards are still a little bit limited. Home-based care remains a priority because there's not enough facility-based care available. We certainly have challenges in terms of access to appropriate analgesics. And that's of course ironical because one country in our region is producing 85% of the world's opium. So it should be available in the region, but it's not. And it's of course a real challenge for governments also to balance that substance use agenda with need for opiate supplies for people needing palliative care. And then, to be honest, also I think we've seen a lot of health professional migration in our region, not only between countries, but sometimes within countries from public to private care, and also sometimes from, I think, psychologically stressful jobs, such as cancer care, to other fields of healthcare, especially nurses. So we need the right incentives, I think, to help these people. In terms of data on palliative care in our region, we have, with the support of Universidad de Navarra in Spain, produced, I think, the second edition of Assessing Palliative Care in Our Countries. That's a report you should be able, free of charge, to download it actually. And it's work in progress. There was, it's ongoing work. We're also having now a palliative care regional expert network. We're having special editions in our in-house journal on palliative care. There's a link if the presentation could kindly be shared. It's all free access. Indicators are developed and capacity building is going on. So palliative care is really, I think, a very important developing area, especially in our region, but I know also in other regions. And that's why I'm highlighting 2 slides. Last but not least, and I guess this is close to what we're discussing today, we are really keen to scale up on meaningful engagement with people living with NCDs, including cancers, of course, and also particular age groups that perhaps we have neglected, I'm honest, in the WHO at certain stages of NCD prevention and control, especially young people who are wonderful advocates, very much feel concerned and feel not fully involved yet. We are learning that again and again. And I believe that in our efforts to come back to our agenda that we had before COVID and that was derailed by COVID in many ways, we want to engage even more with those people, and we need partnerships, and we need to network and enhance our efforts together. So in terms of our collaboration with patient groups, it's already ongoing in cervical cancer and childhood cancer, patient engagement. The colleagues from headquarters will talk about it later on. Knowledge resources. So please also check our websites, not just Geneva, but the 6 regional offices of WHO also have additional very important resources if you are interested in particular data on those countries, of course. And then finally, also, I think it's a learning process in terms of patient engagement and how to do that most effectively in our region. And we do have a lot to do with stigma. I can say that because in our department, our setup in Cairo, in the regional office, mental health and substance use is part of our portfolio. And that's by following the United Nations Political Declaration on NCD 2018 from the General Assembly in New York, which calls for mental health actually being to some degree discussed jointly with other non-communicable diseases. And that is really important because there's a lot of parallels, of course, between what we're discussing dental stigma in mental health, in the past at least, HIV, for example, communicable diseases, but also to a certain degree cancers and chronic diseases. So we want to jointly work with. So with those few slides, I would like to thank you for your patience. And
thank you very much, Dr. Asmus. I think it was a brilliant coverage of the whole picture. My next speaker, I think, always says that don't reinvent organizations and don't reinvent networks. What you have there, build them and use them. I'm so glad that Dr. Sonali Johnson from UICC is here. We are a member of UICC. Like many of you here, some of you, we support UICC because UICC gives more than the patient perspective on it, but also gives the what I call non-state actor perspective, and it covers everything. Dr. Sonali is the added advantage that she's heading the knowledge, advocacy, and policy section of the UICC, and she'll give the non-society and non-state actors perspective of cancer care working within the WHO. Dr. Sonali, please.
Thank you very much, distinguished colleagues. It really is a pleasure to be invited here to represent UICC. We are a membership organization based in 170 countries with more than 1,200 members making up the world's cancer societies, foundations, hospitals, research centers, and ministries of health. And I'd like to say that this is also a very important year for us. It's our 90th birthday. We were founded in 1933, so we are proud of that milestone. And throughout our long history, you know, there are many things that we are very proud of. And I'd just like to talk here about how important patient organizations are to the work of UICC. They make up 40% of UICC's members, and they represent 461 of our members currently. And they include large cancer patient organizations, coalitions such as IAPO, the World Ovarian Cancer Coalition, the Lymphoma Coalition, as well as other cancer site-specific and regional coalitions of patient groups. And over the last years, we have been really looking at how we can work more closely with our patient groups, how we can work with them on capacity building and on advocacy activities, particularly in their regions and globally. All of us here will agree wholeheartedly that cancer patient organizations serve as invaluable platforms for individuals to connect, support one another, and share their experiences. They possess unique insights into the challenges faced by cancer patients, by their caregivers and survivors, enabling them to provide invaluable input into policies and programs and healthcare systems. By engaging these organizations in advocacy, we unlock a wealth of knowledge and first-hand experiences that can shape more effective policies and programs. UICC's work therefore complements other key global initiatives that support the patient voice. So the WHO's framework on the meaningful engagement of people living with NCDs and the NCD Alliance's Our Views, Our Voices initiative. Our goal is to create a community of patient organizations that work more closely together, that learn from one another, exchange, create synergies, and support each other in advocacy to support patient-centered healthcare. In 2018, UICC launched the UICC Patient Group Mentoring Program. It's a tailored mentorship program dedicated to building the capacity of patient groups at the regional level. And the main objective of this program is that patient groups are heard and engaged as key partners, not just in discussions on cancer, but in broader health discussions at global and at their local and regional levels. The program was launched in 2021 in the Emirates region with 9 participating organizations from Morocco, Egypt, Algeria, Lebanon, Kuwait, and Palestine, with small grants awarded to organizations to enhance their activities and advocacy and patient support. And this included support towards a campaign in Morocco that aimed to sensitize public authorities, medical practitioners, and the general public about the healthcare conditions of rural populations to close the rural-urban divide that we often talk about. In Palestine, the Sunrise Group Palestine Initiative for Breast Cancer Patients and Survivors gathered patients from the region where they connected and discussed their experiences and challenges. In Lebanon, the Lebanese Breast Cancer Foundation developed a booklet to accompany women when diagnosed with breast cancer, assisting them in all stages of their treatment journey until the end of treatment. And the Barbara Nassif Association, who produced a short awareness video to support cancer patients in Lebanon in times of medicine shortages. When we talk about creating the conditions conducive to personalised cancer care, high-quality cancer data and analysis is fundamental. And I was very happy to see the importance of cancer registries included in the position paper for this meeting, and it was also mentioned by Dr. Hammerich in his speech. While the goal is to shift late-stage diagnosis down towards early-stage disease, registries do not always include stage data in their reports, and without this data, it is difficult to see how well early detection programs are working. UICC, as part of its TNM classification on staging, with support of Friends of Cancer Patients from the UAE, worked very closely with the International Agency of Research for Cancer on a 5-day course to explain the main staging systems in cancer, which staging systems are used in which settings, so clinical, registries, or both, and the principles of staging. 14 participants from cancer registries in 12 countries in the region attended the course. And following the workshop, we sent out a survey to assess current staging practices with information collected from 23 population-based cancer registries in 16 countries, in EMRO, of which 12 had national coverage. Despite being widely recorded, stage was not routinely included in half of the cancer registry reports. And other problems that we found included multiple classifications and usage and variability in staging practices within countries. So therefore, improved cancer surveillance across the region will help tailor the different cancer control strategies and monitor their impact. Moreover, will also support personalised cancer care. So now, as I would like to talk a little bit about civil society and their participation in global advocacy, I just want to say how important it is that civil society participate actively in national cancer control planning. While participation is included in its own P, the engagement of civil society organizations is essential to all of the 5 Ps. While many national cancer control plans state the importance of involving CSOs in their development and implementation, very little detail is provided. There is a need for more emphasis and advocacy here in investing in capacity building and the meaningful involvement of patients and putting in place processes and mechanisms at the national and subnational levels for their active engagement. I would also like to talk about the importance of patient engagement in global advocacy. Last week I returned from the high-level meetings in New York, which, as many of you know, we're looking at the multi-stakeholder meetings on tuberculosis, pandemic preparedness, and universal health coverage. And I was really impressed and struck by the collective power of the voices of civil society. They were represented by patient groups, people living with NCDs and disabilities. And also what I found so striking and encouraging was that many member states were there, listening actively and looking for ways to collaborate. And these groups, these civil society groups, argued for greater engagement in decision making, for representation in health discussions in their respective countries, and ways that they can actively work in constructive partnerships with their governments to improve quality of life and well-being. Sometimes it feels like meetings that happen in Geneva and New York are very political or too distant from what's happening in people's lives. And many of our members say to me when I try to engage them in the work we're doing, but what does this have to do with me, Shonali? Do we really need to get involved with this? And I say yes, because it does matter what happens in Geneva and New York, because the issues that concern you in your day-to-day can be brought up into the global policy level. And when they form part of the agenda, they become more visible at this level. And then, when they make their way into resolutions or strategies, they do have an impact because they can be used as advocacy hooks in countries. They provide that hook to be able to do a targeted advocacy campaign. So to this end, UICC organises regional dialogues so that we can support our members to do that, to feel more confident, to be able to have that messaging, to be able to bring their experiences and their technical expertise into a policy-centred message. In fact, our team has just returned from Manila. We did a regional dialogue in the Asian region and in the Asia Pacific, and we talked about women's cancers, sharing experiences and regional networks. And at that meeting, we brought together civil society, patient groups, ministries of health, researchers, oncologists, and others working in the NCD community. And we do envisage holding more of these in person and hope to do more of this work in EMRO, both in person and virtually. Finally, in developing personalised cancer care in EMRO and elsewhere, when novel technologies are developed like multi-cancer early detection tests or new therapies, we must ensure that patients' needs and preferences inform the development, planning, and implementation of these technologies. Incorporating the patient and survivor voice into the protocol design for emerging technologies can help eliminate the barriers and improve their efficiency, impact, cost, uptake, and acceptability. By harnessing the expertise of patients, we can create a brighter future for all cancer patients. Thank you very much.
Thank you very much, Sonali, for that coverage. I think you're absolutely right. For 90 years, I think you represented that civil society perspective, and it's kept everybody on track, and I think, and given us that respectability, amongst the high-level policymakers. So thank you for your effort. I just got a nice email from the chef. He says the food's ready. Only when I never been to the hotel where the chef actually emails and says food's ready, so he's preparing. So let's finish this panel quickly before we insult him by getting his food cold. I'll now call up the next for a panel discussion. Firstly, I'll ask Dr. Ahmed Al-Mandhari, Advocacy Advisor, Align Efficiency Health Consultancy. Come on in. Dr. Sossan has really promoted breast cancer with Friends of Cancer in Dubai and UAE. And I was so impressed the way her campaign was run. She made a very sensitive issue become important family and public health issue in Dubai, breast cancer. We had grandfathers concerned and running and raising money for granddaughters' health, and grandchildren running, grandsons running for grandmother's health. That's the level of achievement this year. In culture, that's complex. So when Dr. Sossan said she would come and help us and looking at personalized cancer care and research and develop this paper, I didn't stop one little bit. I said, let's go for this. This is really, this is that oasis of knowledge that we really need to get in. So thank you very much, Sossan. And then I'll have, Dr. Guy Fons has been replaced by Dr. Mia Olsen for the technical consultant at the World Health Organization, and she's from the global. Again, I think Mia brings in that communications expertise that we do need. We do need that. How do you relay that message cleverly? How do you get those nudges in without having oversense? And as you know, WHO has got the guidelines on infodemics. Please, please, please don't bring cancer results and things on minor studies which have no meaning. Let's control that infodemic. So Mia will help us come through that. Then Dr. Abital Fadil, founder of the Eastern Medicine Institute. Dr. Fadil, you might have seen her papers. Please do read her insight, and I think her long understanding of WHO protocols. She's very diplomatic in her language, but you can see that what the message is. Very hard message, diplomatically put across. Thank you. And again, she'll share with you the challenges patients face as they interact with the healthcare system, what are the pitfalls and how we get them, and what outcomes are. And then for my next panelist is Dr. Ahmed Al-Mandhari. He's the Executive Director of the Women Health and Cancer Program, Ministry of Health. Dr. Ahmed and I met at the Geneva Health Forum, and I was so impressed with breast cancer, his understanding of the issues, the sensitivity and the importance of having that was so impressive for us. I think Gertrude will agree. And it inspired our next phase that we decided to undertake a breast cancer research in 8 countries of Africa and Middle East. And thank you very much for inspiring that. I think you led us that. Without your inspiration, we would have gone forward. I think we've got that confidence. And then I have Janelle Krishnamurthy, and Head of Public Policy and International Affairs. I think Dr. Krishnamurthy really come bringing that industry perspective, but with a warm and understanding. I think your experience across, you delivered, you know, let's put it this way, simple, you delivered on time. During the pandemic, you delivered. When we called for the personalized cancer monoclonal, you delivered. And you have that sense of working with patients. I think Merck has an amazing policy on including us in and making us feel home with yourselves. And I think we sit eye to eye. That's something we are always on, that patient organizations are speaking eye to eye, rather than being addressed on. So thank you very much for being with us here in Geneva. Now I will, have I missed anybody? Okay, no, thank you. Okay, so I will start to the panel discussion firstly. As I said, depends on your viewpoint. It's either the 4 brothers and a sister, or 4 sisters and a brother, about why, where, when, and how. Start with Dr. Sosan. Sosan, what is the Personalised Cancer Care Alliance? What's that alliance advocating for? How does it fit with the WHO's meaningful engagement framework?
Thank you very much, Kawaldeep. Good evening, everybody. I'm really honored to be here among all of you today. As Kawaldeep mentioned, I have a 20-year track record when it comes to patient advocacy as my former role as Director General of Friends of Cancer Patients. And now I have been doing a lot of work as an advocacy advisor in the region and globally. And one of the things that I'm very proud of is supporting IAPO in producing the Personalized Cancer Care position paper and the alliance work in the region. So in 2022, IAPO started by formalizing the Personalized Cancer Care Alliance. And throughout the year, there was almost 4 to 5 meetings of cancer organization in the region, cancer society, patient organization, scientific leaders as well, oncologists, patient experts, and throughout these meetings there was lots of discussion around what does it mean from a patient perspective to have a personalized cancer care. And out of that came the position paper, which I would recommend all of you to actually look. There is actually a paper in front of your round table, where there is a QR code where you can scan and actually download the position paper. And I'm actually, I was very proud, Kawaldeep, to sit here and listen to Dr. Shonali and Dr. Osmas really quoting the 5 Ps, because this is really the fundamentals of the work. What is very important about this position paper is actually it hasn't been written by scientific leaders. It has been written by the patient organization and the patient community themselves. So this is what makes this paper very seminal in our time. It's because it came out of almost a year work of patient organization coming together, discussing with leaders, discussing with oncologists and scientific leaders what it means for them in our region to have personalized cancer care. I think also it's a very important paper because it reflects on the, the recent framework of meaningful patient engagement, which actually just came, the announcement came last week, right? So when that came, I mean, we are really in a great position right now as an EMR region, and I'm sure Dr. Tihal will speak about the region. We're in great position right now to actually advance the personalized cancer care from a patient perspective, but take it to a more policy and policy and also advocacy level to change policies to have more personalized care being affordable, but also being accessible by the patient. I hope I actually answered your question.
Thank you. Thank you. Now I'll go to the other end of the table, to Dr. Janela Krishnamurthy. You've seen what the patients are saying. So beyond the conventional role of what the industry plays, I already kind of let the cat out of the bag. In cancer care, how do you see the industry advancing patient access to and patient advocacy for cancer care?
Thank you very much for the question and also for putting on this critical discussion here. I come here, I'm trained as a pediatric clinical psychologist. I used to see individuals that are experienced in cancer and specifically kiddos. And I feel like that is what drives us, drives me every day. It's one thing to come up with a medicine or a vaccine. The next thing is we have to get it to the individuals. And we have to think about this from end to end. First and foremost, I want to prevent this from happening, right? Then we need to detect this. And then after that, treat, and then hopefully live. And to do that, the only way we can do that is with partnerships. This is a team sport, I want to say. And if we're going to eradicate cancer, we're going to have to do this together. So I just look at this as industry needs to do this based on research and evidence, and then we need to work with you all on evidence-based interventions to deliver these care. And then lastly, we really need to take this evidence and research to develop policies and solutions so we can help governments really deliver the appropriate funding and also cancer control plans that can be sustainable and informed by the patients, caregivers' voices, because that does need to be at the center, because they are the ones that know the best.
Thank you very much. And I'll move on to left right there. Thank you. Dr. Ahmed, I know Egypt has really been advancing in looking at women's health and putting it forward. You in the center, how do you see things moving? I know you're going to cover this issue at the Africa Health Con in a big way. I can see the presence of the speakers list. It's amazing. All the top women scientists, healthcare workers, very thank you for that. I should have thanked the minister. Well put up. So how do you see things working? What led to the Women's Health Initiative, and what are the main objectives of it? And do you collaborate with patient organization to reach these goals? At what level and how?
Thank you so much for this chance. So Egypt has a strategy for universal health coverage. Also has a strategy moving towards early detection and prevention instead of spending a lot of the budget on treatment, which is the sensible thing to do. In 2018, when they started the strategy, they thought that there are certain diseases that cannot wait until the universal health coverage is complete and completely rolled in all of the country, which would take 10 to 15 years. They started with the biggest health issue in Egypt at this time, which was hepatitis C. And then based on the experiences of hepatitis C, you discover that you have capabilities, you have a network of primary health facilities that you can use, you were able to roll the service across the country. You built trust with the population. You delivered a service and you delivered treatment, and you kept your follow-up going. So people started, if we can call it a brand called 100 Million Healthy Life. So then came the idea, then let's look what else we can do. And the biggest health issue then that was presented by the council, the National Council of Women, was the delivery of treatment for breast cancer. And then we started looking at how we can do a program for it, which was extremely difficult. The infrastructure was very effective. We are 100 now we are 105 million. The age group that we are targeting is around 32 million women. And it's 19 million women is the age of the screening for breast, but we increased the program, or we made it bigger in terms of we need to have the culture set. So we started from age of 18 years old, but what we do is that we do NCDs, we screen for diabetes, hypertension, obesity, and we do questionnaires for reproductive health, which we use later on to do what we call a family development program. So back then, the number was 32 million women. You have to reach them, how you can do this, what's your capabilities, and then we started, because we were talking before this, and in order to do a Western-led program, it was impossible. No way that you can go in a developing country with limited resources, and you ask to do for every woman above the age of 40, let's do a screening mammography from day one. You can never do this. So the question was, either you do your capabilities and then do the program, which might take years, and you will always be increasing in number. So the other thought was, let's do what we can and build on it and move forward with it so that we reach the standardization in 3 to 5 years. And this is what we're trying to do. So today we were able to reach 20 million women who came once and twice and maybe 3 times. So we did 35 million examinations. We did more than 500,000 imaging, 37,000 biopsies, which was a major bottleneck. And before the campaign, we had only 3 labs that were qualified to do immunohistochemistry, which is a higher step of the basic pathology, but it's not a very highly technological step. Today we have 22 labs across the country, which decreased the number of service delivery. So a female would start treatment 250 days after suspicion at the first point. Today it's 55 days. Pathology was, it took 156 days to do the immunohistochemistry. Today we do it in 21 days, and we're pushing to do more. Building on that, we started to look at the next step. So we started to look about how we have to do what we call personalized care, how we should go for prediction, which is a step even before what you can call early detection or screening. You started doing a network of genomic labs where you can start doing a program where you predict a certain type of cancers. We're working with Gustave Roussy on this program, and we started, so we work on different levels, increasing the capacity, or we do capacity building in all aspects, and we focus on the human resources. So for example, one of the biggest challenges that we had, that we did not have enough physicians, for example, to do the very basic step at the primary health care. So we were able to approve the idea that you can depend on nurses. And we started doing a research for a device that you can use to increase the sensitivity of the basic clinical examination. And then you needed to have more oncologists who are qualified to deal with breast cancer. So we had a program, a diploma for breast cancer with Northwestern University that's rolling right now. It's going to continue for 3 years, and it's unlimited numbers. So we're actually now considering that we can have African join because it's an online course, and you do a clinical workshop for it. What we did also is that we had a certain number of mammograms. We did our studies, and we were able to know that we have a defect of 250 mammograms. So we ordered 100 at one shot, which is a big budget, and it's a big number. But when you're dealing with 100 million person or 30 million women, you need to. What I want to say is how did we were able to do this is we were able to do this by providing the service close to the patient, or actually to the woman. She's not a patient yet. So we took the service to her. We did not only ask her to come, we did not make it hard for her by telling her you have to worry, you have to do this and this, this is the message, this is the fear, this is the problem, but then you don't know where to go, it's not close to you, you have to do a lot of trouble, and even when you find the problem, you don't know how you're going to pay for the treatment. So you had to answer all this question before you start, and then we were able to do that. Thank you so much, and sorry I took a long time.
No problem. Thank you very much. I think Dr. Salson has also been on the humanized healthcare programs and promoting that. And there again, we said closeness of service to homeless, humanizing it. Now comes the next question, and I was saving it delivery for this because it's very important. When the framework was coming up for discussion, but before the framework, I social remembers as well. So somebody said, what is the patient journey? We are trying to improve the patient journey to cancer. And there's one woman who stood up, and she's Arabic speaking in France, so it was beautiful. She says, this is like 1001 Arabian Nights, you know. It's like Simba traveling. I am here, my health professional is there, my health clinic is there. I am going around in circles and circles, and this way, that way. This is not a journey, this is a maze. So, coming to you, Dr. Bilal, can you share with us the challenges patients face as they interact with the healthcare system? Is this not a journey? Is this a symbol? What issue do you see that have impact on patient health outcome? What are the most important of this journey?
Thank you very much. Good afternoon, good evening, everyone. So I'm a personal advocate for patient engagement, and always my theme is patient engagement is critical for the outcome and the success of the treatment. But before I go that, I have something to share with you. The advocacy. So I'm advocating for one of Dr. Asmas had referred to cancer data in the region, and this is something I've done by the civil society in collaboration with INCTR and WHO colleagues. Are very thankful for them. So this is a special report putting all data related to different areas of cancer in our region. This is one. And the second one referred to what is the question. We have done, I'm representing the civil society, and before civil society, I'm a WHO staff, retired staff. So during my experience with the 22 countries, one of the huge gaps I noted is there is a difference between what we say in WHO and Ministry of Health and what is really the situation on the ground. There is a need and challenges which has not been addressed. And whatever we produce, because the role of the WHO putting guideline and strategy and things, which is excellent and great, but these how could be translated to the patient need and even sometimes to the healthcare provider need. I found there is a huge gap in this area, so this is unmet need. When I retired from WHO, I started to work with the civil society and first with the Global NCD Alliance because, there is a history in it. I noted that the people who took the NCD agenda and the cancer agenda to the high level, to the UN, is the civil society. The civil society is very active. They are the voices of the people who took that to the higher level. And unfortunately, in our region, we have a gap in bringing the voices of the civil society and bringing the voices of the patient. So this is what motivates me to work with and creating a network of regional civil society and trying to find and identify the gaps, what the patient, how we can empower the patient in our region. To empower the patient, first we need to understand what are their challenges. So we did started in 2017, we did different series of community consultation, we call them. As a group of civil society, we did a community consultation. To my surprise, I am a person who's coming from the region, understanding the culture and everything. But the story which I heard from women who had lived experience of cancer and the challenges, it really was eye-opening for me. And this is why I continued into this exercise. We did it in many countries. And everything you had mentioned here is there. There is the stigma. There is the later stages of diagnosis. There is a lot of myth and cultural difference. And these all we had reported in what we call it testimony of women, different women from the region. And it is available on our website. It's a network of the EMR and CD. In addition to that, the main things which women came with, and especially, we did it among women in a settled and also Syrian refugee, the main challenges, they are suffer cost, and I think this is applicable to other culture. The cost of treatment is not affordable, and the access to treatment and the communication. So the communication was a major issue, because what we talk about is regarded as a jargon for the women who are, the compliance of a treatment and the compliance with screening has to be really understood by the public, not by, by us. Because we always talk to each other, like sitting here talking to each other, is a high level of communication. But to the community, to the women, and to the people on the ground, we need to come to a different level of communication. And there is a major issue in our region is the structure of the health system. Even with the good country who have high resources, the structure is so confusing for the women and for the general people who are affected. They have a duplication of services, and it is not easy to go through that journey. I hope I
yes.
addressed your...
Yeah, but you have described exactly what this person was feeling, that this is Sinbad's voyages.
Yeah.
Thank you.
Yeah, so this is, I think, like now, working with colleagues from WHO who comes to the idea and putting the framework for the engagement of patients. This is a golden opportunity for us as advocates for patient engagement and the critical role of patient and their lived experience. I think this gives us the support and the power to do more work in the region for encouraging the patient engagement. Still, we have to do a lot of training for the patient and empowering them as well to talk, to voice their need, and also training of our colleagues in the civil society, how they could work with the patient to empower them.
Thank you much. And it's time correctly, I think, the follow-on is very easy again from Mia. The question is this. One of the best things I had when you launched the WHO's framework with lived experience was everybody. The researcher was a patient double transplant. The system was cancer survivor. Somebody had type 1 diabetes. Somebody had this. So it was like a whole group of patients in that. How did you get them to come and talk, as you said? How did you manage to bring them out and start saying what they had to say? What was it like? So the question I'm asking you, share us with us what the WHO framework with lived experience is, and what needs to happen for it to go forward, And the line that came out through very clearly was that lived experience is expertise in its own right. Yeah.
Absolutely, and thank you so much for having us. And Guy is big shoes to fill, and I appreciate your patience as I jump into this. By way of introduction, and I'll keep that theme going, my start in this work is through lived experience cancer advocacy. I am a childhood cancer survivor, and a lot of what I saw in my journey was things that Dr. Asmus and others were showing, is that for too long, I think cancer has been a condition where the outcomes of people and their families are too often determined by the structural inequities and of where you're born. And so my journey with cancer is very different than others. And I think cancer also is an entry point, and there's a lot of power in opening up a conversation well beyond cancer itself, but also across NCDs and mental health. In terms of your question and talking about the framework, I'm going to start with the definition of what meaningful engagement was, and that definition came through a co-creation process very much informed by people living with who were already there and knocking on the door and really leading the work over many years. The WHO defines meaningful engagement as the respectful, dignified, equitable inclusion of individuals with lived experience in a range of processes and activities within an enabling environment where power is transferred to people, valuing lived experience as a form of expertise and applying it to improve health outcomes. And I think so many of the themes in the framework have already been shared through speakers all throughout this event. It was a participatory process. Certainly there was calls for invitations and a lot of encouragement and capacity building to bring the communities together across regions and across the consultation process over 2 to 3 years. But so many of that leadership was already there, and so it was really taking the best of a moment to lead this forward with WHO. The framework is a technical product that is a set of recommendations for WHO and member states to implement and support individuals with lived experience and to include them in policy processes alongside UN partners, academic institutions, and civil society partners. The principles of the framework really kind of fall in, or the structure of the framework falls in 2 sets. The first part of the framework is really around principles, and so much of what we've been talking about has been health equity and around addressing some of the power dynamics. Certainly recognizing WHO has a part to play in those dynamics, but looking at rebalancing power to really bring people with lived experience into rooms and in settings they haven't always had a chance to not only come and tell their stories, but to really be integrated throughout every part of the policy setting process, program implementation, planning, monitoring and evaluation. It really doesn't sort of start and end in any one place. It's throughout the whole process. The principles in that first section and that have been defined through this co-creation process are dignity and respect, power and equity, inclusivity and intersectionality. No one person living with any condition is one singular thing, and it really is the power of everyone coming together across identities and across intersectionality, commitment and transparency, and institutionalization and contextualization, and really kind of bringing this across different regions and countries. In thinking about how to move forward meaningful engagement and to bring that participatory process and to bring the inclusion and engagement of people with lived experience, some of what will create that enabling environment is tackling things like sustainable financing, and really if lived experience experts are experts commensurate to any other form of expertise that needs to be sustainably financed. People need to be compensated for their roles redistributing power and really thinking about rooms like this and where decisions are made and how we can have it be a more inclusive, participatory, equitable process. Elimination of stigmatization, none of this can happen without that being a central piece of really tackling stigma and the challenges that people with lived experience face. Integrated approaches, both kind of integrating people with lived experience throughout, again, every part of the process, but also integrating across other health agendas and really looking at cancer, across NCDs, across mental health, across some of the other parts of the agenda. Capacity building, many people have talked about, and capacity building not just of people hoping to enter the process, but of the stakeholders, WHO member states, who are already at the table, and institutionalizing engagement and really making sure it's part of the process. So I will stop there. There's much.
Thank you very much. Now I'll do a little change. I know Abby is going to go crazy on this if I do that. But this is for NSA actives, especially the IFMSA students there. That guys at the back. Could you raise your hands? Okay. I know you have been dying to ask the questions at the floor. This and the agenda keeps swinging and we haven't been given that opportunity. Let me get your voices tuned up for tomorrow. Have you got questions for the panel? Stand up, pose your question, and let's put you on the spot, because tomorrow that's what is going to happen to you in front of those ministers. We don't need to. Come on.
Hello everyone. Can you hear me?
Yeah.
I think it's not working.
Just switch it on.
Okay, I have a loud voice, you know.
Okay, go on. That's what you need tomorrow.
Hello? Thank you so much. Thank you. Thank you for our great panelists, for all the information you have shared with us. My name is Mohammed from Egypt. I'm a fresh medical graduate and I'm a part of the International Federation of Medical Student Association. And I have a very small question. I'm quoting the words you have been mentioning now regarding that the capacity building is not only for people who want to be engaged in the process, but also for the stakeholders and other WHO officials who might help in the process. And here I want to ask about what about capacity building to other stakeholders from the civil society who want to also be engaged in the process, and especially from the youth and young people who are have a big experience in the field of global health, and they want to be a part also in the process. Thank you.
Thank you very much. I'll ask the microphones coming out. There's guys that I think Chef Andrew needs to fix the microphones as well.
I'll start because I think there was a sort of directing it at WHO, but I really would like to learn and hear from the other panelists as well. I think, and my people sitting next to me can, one of the things I have written down is it's multidisciplinary. So I know that I was focusing on a little bit of a bi-directional relationship as I was talking through the enablers, but it is people with lived experience, it is WHO, it is regional offices, it is civil society, it is ministers of health industry. Like there's so many different ways to break down silos in the way that kind of power and structures have been built. Youth is a huge part of that, and I think both from cancer happens to young people more than I think we give give the epidemiology credit for it, but also young people have the energy and excitement and really the sort of knowledge of their community that gets taken for granted and can really help lead and shift some of those. So you asking that question is a good start, but let's get you into the process.
Let's see what the rest of the panel thinks.
Yeah, I think I joined here. We have to train everyone. I will give you examples. So before the WHO framework, we have created the supportive environment by training the youth who are affected with non-communicable disease, mainly cancer, in our region to articulate their voices, because they were not able to tell the story to the public and how they tell the story. And this is what we did back in 2017 and 18, and that has created the environment. These are the champions which have been voiced the people voice and they use them in UN high-level meeting as well as in developing the process of developing the framework for the engagement. And I would like also here to request you to visit us and join us as a civil society, because we have a section on youth and we want the youth to be a champion and voices for our region. So it will be good to be engaged in the regional civil society. And we do training for the youth, for the civil society, as well as, I mean, one major thing in enabler is the policy maker, because now how we are going to implement the framework, we need the policy maker to change the policy and bring these people on the table. So they have to also be aware and train on the value of the engagement of the patient.
Okay. Before I go to Susan, I need to ask you. Susan doesn't like the word patient groups.
It triggers me.
I'll trigger you off now. Susan, your response with that in mind.
Okay, so thank you very much for the question. I think it's a very important question because you're actually putting two groups together. You're putting the youth and you're putting the medical professions as well. And that's very important. I think you play a very important role, and I do agree with WHO and with Dr. Tihal as well. You play an important role from a medical perspective, because your generation now understand what it means to have the voice of the patient being implemented. And I think having proper communication skills, which you are developing through your training and education, and in the future, inshallah, when you graduate, you're going to have more of that and how to handle the patient, etc. But also having that, not just a compassionate or empathic attitude towards the patient, but also helping them to understand that both of you are partners in creating the treatment plan and working together to making sure this patient gets what they really want out of the outcome. I come from a generation, and I'm not going to include Dr. Ahmed, but I come from a generation where we were very compassionate, we were very driven to help the patient, but unfortunately the patient were not ready. They always said, "You're the doctor, you know better. I trust you." And I think your generation is going to change that play. You're going to change that. And this is where you're going to shift the game, where now we're trying to empower patients and patient advocate. We're relying on that new generation. And we are hoping that the medical community can also change the game by changing their way of thinking. I hope and I request that your generation can really support in patient health literacy, and also at the same time making the treatment plan a co-creating effort between the both of you. It's not like, oh, this is treatment plan, khalas, take it, this is what you need to work. No, it has to be a co-creating, and that's what we are hoping the future would be. And I think you are the future for that. Thank you very much.
I just want to thank you for the question, but I think everything was said. But the idea that, first of all, you educated us that we are missing a point, that there are certain groups that we did not include in our vision of capacity building, so thank you. But also it brings us to another idea that the table should be round table. This is what we were talking about. So every representative should understand the story of the other party on the table. And the decision and the dynamics should be shared. You should not be telling the civil society or the patient group or the medical or even the policymaker, you should do it like this. We should sit and decide how we should do it together. And thank you again.
I would just say, I think this, you're putting a pinpoint on, finer point on the importance of all of us coming together because we can leverage each other's expertise to help come together from different regions, internationally, global, locally, regionally, so that we really can communicate and be effective in making progress towards our shared goal of having affordable, accessible medicine and healthcare to all. And that's what we're all here for.
Okay. Thank you so much. Let me introduce myself. My name is Wael Ali. I am General Secretary of FIP, International Pharmaceutical Federation, one of the most important pharmacist organization over the world. We have like a member about pharmacists 4 million, okay, and about 147 organizations. My question for you, for all of you, you guys believe in the oncology pharmacist or not? Absolutely yes or no? Yes. Yes. Okay, this is first question. Second question, I never ever listen about the role of the pharmacist here. I never ever, no, I'm so sorry about that. Let me explain more about that. You know, the cancer patient, about 80% of the cancer patient, not suffering from the cancer itself, but is suffering from the side effect of the medicine, right?
Wrong.
Okay.
100%.
Okay.
You have to understand that I'm a clinical oncologist. I can't let this pass.
Yeah, it's okay. I'm talking about the medicine here, about the oncology pharmacy. Okay.
Let's move on.
I mean the side effect, it's okay. But I'm talking about 50% of the treatment of your patient is medicine. Yes, no? Agree?
Yes.
All right, thank you so much. This is a lot of protocols right now about the oncology pharmacy. So we have to make like a multidisciplinary team, it's for real. Starting from nurse, for you as a physician, for me as a pharmacist, for even the patient as a stakeholder, you know what I mean? So my point of view here, Doctor, I'm sorry about that. But my point of view here is the role of the pharmacist right now in 2023 is becoming booming, especially on the oncology pharmacist. The pharmacist, he can do a lot for your patient. Thank you so much, I appreciate it.
Thank you. Could I just answer that and give you as well?
Yes, yes, I'm getting the microphone.
The reason I'll address this first is we have our Global Questions Congress from Friday to Saturday.
Yes.
And at that we had mentioned from FIC, your own chairperson, Catherine Duggan was speaking on this, and she and Dr. Saucer, we agreed on that. On personalization of cancer care, the pharmacist has a central role. This was what, I'm sorry you missed that session. The session was about that. Personalization means through the line, and it means also after the chemotherapy has left, the physician is not being used. The pharmacist has a key role to play. In fact, the pharmacist during the pandemic was the fourth emergency service, and we do, we'll have that issue in the future, but we did mention even in the position. Thank you. Thank you for bringing it up.
No, I'm actually agreeing 100% with you. The physician is a strategist. So the consultant only sets the strategy. The main driver for service delivery, in my opinion, actually is the nurse. And the qualified nurse in tertiary care is the main driver of delivering the adequate service and in the quality of life and in tracking the side effects and. However, in Egypt, we do have huge number of pharmacists, and they now play very big role. Okay, and they play very big role in research, in tracking the patient journey and the patient side effects and the dosage. That we are now facing some criticism with, we criticize the younger physicians that their engagement with the dosage and the side effects is becoming less because they're more dependent on the clinical trials. However, this is only in the oncology centers. If you have small units in certain general hospitals, or I mean tertiary hospitals, they still need to be more educated, more empowered, and of course, the younger the generation, the more they are willing to work as a multidisciplinary team. In breast cancer, for example, not one patient is allowed to get any treatment without a multidisciplinary decision.
Okay. Thank you very much. Now I'll ask Dr. Sarson, the last one. It's about the next step, the call to action. Dr. Sarson, if you could say something on this.
Thank you very much, Kawaldeep, and thank you everybody for attending today, this important session. Again, I would like to remind you this is all for the Personalized Cancer Care Alliance and about the position paper. And what the call of action, what's going to happen next, obviously we are all agreeing that this is an important topic to have more personalized care toward cancer patients. The next step would be there is right now a toolkit being developed for the position paper, and we will be doing capacity building and training in our region, in the EMR. There will be a training happening in Kingdom Saudi Arabia in the next Q3 or Q4, and also we're going to have one in hopefully in Morocco. The reason we chose those two countries, this is a pilot phase where if you go again and read the position paper, you will know that we have segmented action plans according to a high, low income and middle income country in our region. Considering Saudi Arabia to be one of Group A, which is the high income country, and consider Morocco as per the WHO segmentation to be middle income. We would like to start there to train civil society, patient experts, patient organization, to train them through the toolkit of the position paper on how to start now lobbying policymakers to make personalized cancer care, whether it's having better cancer registries, having better policies, or even having infrastructure for genomic medicine available in their respective countries. So that would be now the next phase. And of course, as we mentioned through all this whole panel, this is not a one-man job or one woman or one-person job. This is a collaborative effort focusing on the 5 principles of the 5 Ps. Thank you, Kawaldeep.
Okay, please do access that call to action. And now just to say why we patient organizations are here at WHA and what we bring. Sir William Osler said that physician learning, a physician who doesn't consult his books and evidence base is sailing in choppy waters. However, a physician who is not learning from the patients is not sailing on any sea whatsoever.
Absolutely.
So this is why we come here. We said the patients have to come in with ideas, and I'm thankful to WHO. My thanks now go to the Director General for WHO for having delivered us from one of the once-in-a-generation pandemics. So Dr. Tedros, thank you very much. As a protocol, we would love to see you here, but we know Jackson. Secondly, I must thank industry for this. I think Famamia to bring us all together was a great understanding of what we needed. I said to her, but we have an important occasion here at World Health Assembly. We must discuss this. We may be talking here, but the ears we are directing to are sitting in there. And we had our audience from YouTube who have joined us, the hundreds, and maybe 500, 600,000 now, 600 join us. We thank you for helping us along, and do see the stuff on the YouTube. And lastly, I think I would say personally at the level to Abby, I must thank her because the level of enthusiasm she brought to this project and the way she brought warmth and understanding, and also thank Abby's children as well. In between calls coming, so-and-so's fallen down, come back, but she managed to keep us all going. And at the last stages, you know, when we were really struggling to put this together, Abby stitched everything out. Abby, thank you very much for the personal confidence. And all I need to say now is, we can discuss the networking. You have a great, we'll have a dinner. I don't want to disappoint the chef, Sherry. All I'm going to say to him, I'm sorry, we are not Swiss, we are foreigners.
Especially the good chef.
Yeah.
I just want to share.
One second. Last word, and then let's go for the dinner.
My name is Hani Nassar, founder of Barbara Nassar Association for Cancer Patient Support in Lebanon. I want to share our experience. We launched 1 year ago an academy for cancer patients in Lebanon. So we gathered cancer patients according to their types of cancer. In this academy, cancer patients became expert patients. We worked with the oncologist and the advisory board and the association to educate them and support them psychologically also. In a few months, we will launch our cancer center, the first cancer center for supportive care, like art therapy, music therapy, yoga, Zumba, all types of supportive care there. So I invite you as the WHO to support us for as capacity building and all what we are doing there. Thank you.
So I'm so glad you stepped in. We have not covered the third level of countries that transition through difficult times. We will have a meeting possibly. We have got you in mind. Thank you.
I do have a point around sort of intention to action. WHO, the framework is a framework, but WHO is going to be launching an implementation initiative starting in the Amana region across 6 countries, and so it will be a chance to help kind of understand the different stages of it, is setting the scene and really understanding kind of a desk review, stakeholder mapping, all of what we were talking about who is in that multidisciplinary group, but also holding dialogues to really listen and learn, and to hear some of the examples that have already happened, and then to really strategize across all of the strategists in the space. And so just the point of kind of, it's so inspiring to hear all of the work, and there's more collaboration to come.
Okay. Thank you. A hand for the panel. One hand for yourself as well. Please slip up. Don't tell Henry I'm here. I'm not going to do it.